Dear friends, I'm very happy to be with you for this conference. As Professor Yehuda proposed me to join this meeting with his colleagues and friends of the US and UK, I was honored and I accepted promptly. But soon after, I became anxious because of my poor English. I began then to learn to speak with a charming young Canadian teacher. My English maybe improved a little bit, but my French is still not too bad. So I ask you, I ask you to be indulgent. I am not able to speak with a speed of 200 words a minute, like some of my colleagues. I am coming from Strasbourg, France, situated on the left edge of River Rhine, between the Vosges in France and the Black Forest in Germany. As you know, in Strasbourg are situated the European Council, the Court of Human Rights, and our Parliament. Strasbourg is more or less a small town with an old and big university, including 40,000 students. Mulhouse is the second town of our region, Alsace. It's situated near Basel. After the Second War, we have had a lot of wounded soldiers, and we built for them a new rehabilitation center called Centre de Réadaptation de Mulhouse, actually devoted to spinal cord injury, stroke patients, and TBI. This center is also involved in vocational rehabilitation and orientation. It's the biggest of France. This center is participating in a European platform for rehabilitation with 18 other centers spread all over Europe, including Greece. Before starting with the pathophysiology of brain injury, our subject today, the second time, I would like you to remember a few remarks. To improve the results of late outcome of TBI patients, we need specialized multidisciplinary neurorehabilitation teams working close together with the medical team involved in acute care. Second remark, we need also a new conceptual approach of the brain-skull grouping, because it is not only the specificity of the brain parenchyma who explains the consequences of TBI, but the close links between the skull and the brain. If the brain is protected by the skull, he is also a prisoner of an inextensible box. This close linkage explains that the primary lesions can be enriched by an ischemic anoxic secondary component, a modification of ICP. We are working now with a new lab in research called the Biochemical Systems Transport and Safety Research Team. It's one of the 4 teams in the world involved in a modelization of a head injury prediction tool which is able to predict the risk of skull fracture, subdural hematoma, and neurological injury. The third remark is, as a neurologist, we are situated on the left wing of this flow chart, involved in what we call impairment and structural lesions. Never forget that any discussion of the late effects of closed head injury must begin with the obvious but fundamental observation that the damage sustained by the brain is the greatest factor determining the eventual outcome. This is, I believe, the doctrine of a neurologist. This is another flow chart due to Coadon. Coadon is a surgeon, a neurosurgeon in France. And you see here that TBI is an important cause of handicap and therefore must be considered as a public health problem and need a lot of money. Finally, but very quickly, I would say some words about the incidence. The incidence rate is the number of new cases of TBI in a defined population within a calendar year, usually expanded as per 100,000 per population. In a recent review in the European Union, an overall average rate of 235 per 100,000 inhabitants a year was obtained. So about 6.5 million people in the European Union have some TBI-related either impairment, disability, complaint, or handicap. So it's not it's an important question, TBI, much more than other neurological problems. The highest number, as Professor Flanagan says this morning, the highest number of incidences occur at the two extremities of life, among children, young adults, and the elderly. The highest incidence is among persons aged between 15 and 24 years and those older than 75. At all ages, males are about twice as likely females to experience TBI. Now let us go to the main subject. What's about structure and function? TBI is perhaps the root of behavioral neurology. As you can read in your books, evidence from the antiquities suggests that there were cases of neurosurgical interventions for brain injuries in Chinese, the Inca, and the Greeks, among others. The first written document describing brain functions and symptoms produced by brain injury was an Egyptian medical papyrus. It seems that the Egyptian physicians were aware of the fact that symptoms and signs of injury to the central nervous system could occur far from the actual site of that injury. The papyrus mentioned how focal damage done to the head could result in impaired visuomotor coordination. It also mentioned the fact that the deficits usually occurred on the side of the body opposite to that of the head injury. We can see that all over 5,000 years ago, there was a concern with relationship between brain and functions, brain and behavior. Alcmaeon of Croton, one of the first neuroscientists, argued that the brain was the central organ of sensation and thought. During the golden age of Greece, other writers like Plato, for instance, accepted and extended Alcmaeon's idea that the brain was essential for thought and mind. Over the centuries, the study of war wounds, penetrating injuries, made a major contribution to our understanding in brain behavior relationships. In specific, Cushing's attention to antisepsis and early debridement produced improved mortality figures in World War I. Experience during World War II, then the Korean conflict, the Vietnam War, and the Algerian War taught neurosurgeons that rapid surgery could produce excellent survival statistics. The most important development in the evolution of head trauma acute care for the neurologist are the introduction of CT scan by Hounsfield and colleagues in 1970, and later MRI, but also the introduction of the Glasgow Coma Scale by Teasdale and Jennett in 1974. Neurosurgical care progressed significantly in the last 25 years all over the world. The good news from this progress is that the survival rate of traumatically brain-injured persons has increased dramatically. The bad news is that improved survival rates have also led to a large increase in the number of patients with behavioral and cognitive disabilities. A short word about definition. The term head injury is commonly used to describe injuries affecting not just the brain, but also the scalp, the skull, maxilla, mandible, and spatial senses of smell, vision, and hearing for us. TBI is usually considered as a result of trauma to the brain from an external mechanical force, possibly leading to temporary or permanent disabilities, which can be categorized in three major areas: cognitive, emotional, executive, with an associated diminished or altered state of consciousness. TBI persons are more or less polytrauma, with multi-system trauma, where other injuries may contribute in secondary injury. Brain damage is not a unitary condition. It is a measurable multidimensional phenomena that require a multidimensional examination approach. The behavioral repercussions of brain damage vary with the nature, the extent, location, and duration of the lesion, with the age, sex, physical condition, psychosocial background, and status of patient with individual neuroanatomical and physiological differences. Muriel Lizac wrote in his book, "Impairment patterns of patients with similar lesions may differ, and patients with damage at different sites may present similar deficits." Thus, also brain damage is useful as an organizing concept for a broad range of behavioral disorders, when dealing with individual patients, the concept of brain damage only becomes meaningful in terms of specific behavioral dysfunctions of their implications regarding underlying brain pathology. A quick word about the classification. Different and multiple classifications are available for neurologists, as you've seen this morning. The most widely used scoring procedure is the Glasgow Coma Scale, introduced by Teasdale and Jennett some 40 years ago, entitled Assessment of Coma and Impaired Consciousness, published in The Lancet in 1974. This score is based on the sum of three components: eye-opening, you have time to read, verbal response, and best motor response. Score is comprised between 0 and 15. Under 8 points, TBI is considered as severe. Between 8 and 12, TBI is estimated as moderate, and between 12 and 15 as mild. This scoring was created by neurosurgeons in order to give severity classification very soon after the TBI. The scoring is valid if the result is that of an early assessment within 6 hours after the accident. However, this tool is also used by neurologists during the evolution of TBI and is considered by us as a prognostic variable of the late outcome. Generally, under 8, there are sequelae, most of the time. Between 8 and 12, some sequelae can be observed, and over 13, 14, there are few or known sequelae after 1 or 2 years. But this is an approximation. The classification is here, and the percentage is represented on this pie chart. It's the same as yours. To competently manage TBI, a thorough understanding of the physiopathology behind primary and secondary injury is required. The classification of damage after blunt head injury are divided in two: the primary lesions and the secondary lesions. The primary lesions are injury to the scalp, responsible of chronic headaches, especially in mild TBI, fracture of the skull, either linear or skeletal, surface contusions and lacerations, intracranial hematoma, diffuse axonal injury, traumatic diffuse axonal injury, diffuse vascular injury, injury to facial nerves, and pituitary stalk. This is for the primary lesions. The secondary lesions, the lesions that occur between the accident and the hospital, are sometimes hypoxia, ischemia, swelling of the brain or edema, raised intracranial pressure, and associated vascular change, meningitis and abscess. The contusion, the cerebral contusion and laceration have traditionally been distinguished by clinicians among several different potential sites of cerebral contusion following close injury. We have what we call le coup, that's the impact of the first impact of traumatism. The contre-coup on the opposite side. Sphenoidal ridge. The sphenoidal ridge is a problem that occurs because if the wall of the skull is smooth, the base of the sphenoidal bone is not regularly. And so the brain going forward and backward is lacerated at the bottom, and especially on the temporal and frontal lobes. The fourth localization is vein avulsions on the top of the brain, between the two hemispheres. I believe that the notion of sphenoidal damage is more important, more useful than of the contre-coup damage in evaluating the neurological damage consequent up on closed head injury. The possibility of other impact may rise to lesion in a variety of other intracranial structures. So we can observe hematoma, intracranial hematoma, but before I will say some words, the difference between contact mechanism and acceleration deceleration mechanism. It's not the consequences are not the same. With contact forces, you have injury to the scalp, fracture to the skull, extradural hematoma, surface contusion and laceration, and sometimes intracerebral in the deep gray matter hematoma. With the other forces, acceleration, deceleration, there are tearing of bridging veins with formation of subdural hematoma, diffuse axonal injury, acute traumatic vascular injury. Now, I would say some words about hematoma, because they appear quite often. In the frame of focal lesion, we distinguish extradural, subdural, subarachnoid, intraparenchymal hematoma. So I try to represent the different topography of this hematoma. The epidural hematoma is between the skull and the dura. The dura is stripped away from the bone, and the blood is collecting here in the epidural party. With the subdural hematoma, it's between the dura and the arachnoid. With the subarachnoid hemorrhage, it's under the arachnoid, between arachnoid and the paimer. Some words about extradural hematoma. Extradural hematoma are found in 1 or 2% only of patients admitted to hospital with closed head injuries, but is present in 10% of severe brain injury in the Scottish database. It's an extra-axial blood collection that is located between the skull and the dura, I've said. It forms when blood from torn meningeal vessel strips the dura away from the skull and produces a lens-shaped bulging mass within extradural region. Extradural hematoma appears as a biconvex or lenticular hyperdensity in CT scan. Classically, 80% are associated with skull fractures that tear meningeal arterites, or less frequently one of the major venous sinuses. 20% present with a well-characterized brief post-traumatic loss of consciousness following a lucid interval for several hours prior to rapid neurologic deterioration. These patients can rapidly become obtunded, display contralateral hemiparesis, ipsilateral pupillary dilatation. If untreated, they can lead to decerebral posturing, respiratory distress, and ultimately death. The volume of the hematoma is a predictor of outcome. Patients with more than 150 milliliters of blood have a poor prognosis. 20 to 55 die without surgical intervention, rapid surgical intervention. Some words about acute subdural hematoma. Subdural hematoma is a consequence of parenchyma laceration or from a tearing of the bridging vessels during acceleration, deceleration of the head. These hematoma occur in 24% of severe closed-end injuries, especially in the elderly. They are associated with severe contact injuries or inertial injuries and are often associated with underlying brain injury, especially in the hippocampus area. Since blood can spread freely throughout the subdural space, subdural hematoma can cover the entire hemisphere and is more extensive than extradural hematoma. Subdural hemorrhage may present shortly after the head injury, and rapid identification and surgical evacuation is warranted for any subdural hematoma greater than 1 centimeter at the thickest point, or for any midline shift. Smaller subdural hematoma can be observed with serial scans to ensure no other progression. If not surgically evacuated, the blood remains clotted for about 2 days, sometimes several days, but after weeks the clot is absorbed. If not, is considered as a chronic subdural hematoma. Subarachnoid hemorrhage, small collections of subarachnoid hemorrhage blood is fairly common after head injury, particularly in association with contusion and laceration. Subarachnoid hematoma occurs when blood is released into the space between the arachnoid and the brain. Subarachnoid hemorrhage is a result of the disruption of small pia arachnoid vessels. The presence of blood in the subarachnoid space seems to be involved in the genesis of arterial spasm, which may give rise to ischemic brain damage soon after the injury. The development of fibrous adhesions in the subarachnoid space may also obstruct the flow of cerebrospinal fluid, resulting in communicating high-pressure hydrocephalus. patients with subdural hematomas had significantly worse vocational outcome than patients without. Generally, they perform worse on neuropsychological tests. The presence of subdural arachnoid hemorrhage appears to have predictive value with respect to outcome following TBI. Short word about intracerebral hematomas. Secondary to contusion or in association, some hematomas occur within the brain tissue itself in 10% of patients with severe TBI. They are caused by the rupture of internal arteries or veins in the deep matter, especially in the frontal and temporal regions. They are often multiple and appear after 1 or 2 days. There are also other types of injury. Pituitary infarction, for example, damage to the hypothalamus pituitary system. Among patients who survive severe head injury, disorder hypothalamic pituitary functions may be evident. For instance, diabetes insipidus, which involves the excretion of large volumes of low urine concentration, is the result of a failure of secretion of antidiuretic hormone, sometimes seen after head injury. We can see also cranial nerve avulsions, olfactory bulb injury resulting in anosmia. This is common after TBI. You have to assess this difficulty. But other avulsion can also occur, optic, facial, auditory nerves. But we can also observe focal vascular injury, like carotid cavernous fistula, and more often carotid or vertebral dissection, which are common. Now, diffuse brain injury. There are 4 principal types of diffuse brain injury: diffuse axonal injury, ischemic injury, brain swelling, and vascular injury. The diffuse axonal injury, called DAI, but also TAI, traumatic axonal injury, occurs very often in almost 50% of patients with severe TBI. It causes 35% of all deaths after TBI and is most common cause of chronic vegetative state. The term DAI means widespread damage with the brain, within the brain, which may result from a number of insults, including trauma, hypoxia, ischemia, hypocalcemia. Traumatic axonal injury is caused by rapid acceleration, deceleration of the head, particularly when there is rotational movement of the head. Particularly common following road traffic accident. They may also occur as result of falls from a height and assaults. Patients with TAI are typically unconscious from the moment of injury and have poor outcome with death, severe disability, persistent vegetative state. TAI is characterized by damage to the axons, as you've seen this morning, and in most cases, petechial hemorrhage. Axonal damage results in swollen, transected fibers throughout the white matter, including the corpus callosum, deep gray matter, brainstem tracts. After a period of several days to weeks, there is accumulation of microglia around damaged axons, followed by Wallerian degeneration of axons, resulting in shrinkage of hemispheric white matter, atrophy of the brainstem, and ventricular dilatation visualized by means of MRI. Let us now have a short view about physiopathology and TBI. The core problem is ischemia. Ischemia is secondary to trauma and at the origin of acidosis, but also cell depolarization, calcium invasion, and then cell destruction with also liberation of free radicals. Free radicals, acidosis, calcium invasion leads to cell destruction. Ischemia genesis is important to tackle because it's very complex. For example, hypotension leads to diminution of cerebral perfusion pressure. It's the same with intracranial hypertension, which is at the origin of local blood flow diminution, oxygen disponibility, and then edema. On the other side, if there is an excess of oxygen intake during seizures, for example, or during hyperthemia, you have also a diminution of local blood flow and oxygen disponibility. Potential cause of reduced cerebral perfusion pressure are arterial hypotension, hypovolemia. The first problem you have to resolve is hypovolemia very soon after the accident, when the patient lost his blood. But arterial hypotension is also caused by cardiodepressant drug and sepsis. Intracranial hypertension is caused by mass lesions such as the different hematomas, but also, as we have seen on your slide, by a vascular engorgement, cerebral hydrocephalus. I would like to say some words about a phenomena, what's called penumbra. Penumbra is also seen in stroke patients. You can see penumbra around a focal or traumatic lesion. And if there are microcirculation disorders or intracranial modification of pressure, and this, if the penumbra is controlled, under control, then the function are going ahead. One of the last picture is intracranial hypertension, hematomas, but also brain swelling, hydrocephaly, temporal expansive lesions are at the origin of intracranial hypertension and are at the root of engagement, which is crucial. And when there is engagement, there is actual suffering and sometimes death. This is a short view of biochemical core mechanism. Ischemia leads to acidosis, cell depolarization to calcic invasion. The trauma gives free radicals, and the final result is apoptosis. At the end, we have the Glasgow outcome scale we spoke about this morning. There are two scales, the GOS and the GOES. The GOS is a Glasgow outcome scale. The GOES is Glasgow outcome scale extended. One is scaled of 5 points, the GOS, the other one of 8. And this is your parliament. It's finished. Okay. As a conclusion, I would say that the best outcome are achieved when care is provided by a multidisciplinary team whose collective goal is to minimize secondary brain injury. The intensive care management is complex and requires a coordinated and stepwise approach, including clinical assessment, imaging, and optimization of ICP and CPP, cerebral perfusion pressure. A neuro-intensive care unit serves as a focal point, including specialized neuromonitoring, neuroimaging, with a good understanding of the physiopathology of the injured brain. The outcome could be measured by the two scales, the GOS and the GOES. Thank you very much.
Thank you, Professor Noss, for this global excellent presentation. If there is questions for Professor Noss, I would like to ask you about your patients in your rehabilitation center. They are referring from other hospitals all over the France, or only from this area of Strasbourg?
Could you repeat, please?
Yes.
Sorry.
I would like to ask you about the patients of your rehabilitation center.
Yes.
They are coming from all over the France?
Yes.
Or only from your area of Strasbourg?
Most of them come from our area on the east side of France, but some of them come from the whole country, because I have friends working in Bordeaux, working in Lille or Marseille, which have problems with some of them. So they send them to me in Mulhouse, and I do the same. If I have some behavioral problem, I send them to Paris or to Marseille on the other part of the country sometimes. But the most of our patients are coming from the east part, from Reims to Lyon, on the east part. But for the vocational training, they are coming all over the country.
How
for
long?
Vocational training.
Yes. How long from the injury moment?
For vocational training, some of them stay 12 weeks to make an assessment, to orient them. But if they are educated in a special profession, they stay 24 months. For the TBI patients, we created, after the experience of Mulhouse, a network all over France, and we have now about 30 small units called du Eros, Unité de réinsertion sociale et professionnelle. And in these units run specific programs for TBI, either for going back at home or re-entry to work. And they stay 3 or 6 months. And they are paid during this period.
Thank you.
Thank you.
Other questions?